So I'm going to go ahead and get started. We are live on Zoom and on Facebook. So good afternoon again, and welcome to Ask the Experts, a conversation hosted by SCAD Alliance. I'm Rebecca Freeman. I will be moderating and leading our conversation today. I am a board member of SCAD Alliance and two-time SCAD survivor. If you're new to SCAD Alliance, we're a nonprofit organization founded by survivors in partnership with leading cardiologists and health advocates to advance the science of SCAD. In addition to our independent multi-center iSCAD registry, one of our main goals is to support patients and families. And as part of that, we've developed this monthly webinar series, Ask the Experts. We hope to support and educate survivors and caregivers by engaging in conversations with experts on SCAD-related topics each month. So be sure to check out our past webinars on topics including PTSD, exercise, genetics, and more. Today, we are focusing on the guys. Our topic is men with SCAD. Although there is a female predominance of SCAD, men absolutely can have SCAD too. So today we're going to talk with two patients, Charlie Izard and Jeff Hawksley, as well as MGH cardiologist, iSCAD steering committee member, and all-around champion for SCAD patients, Dr. Malissa Wood. So I want to start with my disclaimer for each that I start every webinar with. And that is, while lots of progress has been made in SCAD research, we don't yet have huge data sets to make firm recommendations that apply to every single person across the board. So the information today is presented based on the experience and expertise of these panelists. But for specific medical questions and details, be sure to talk to your medical team to make plans for your care. The good news is that research is coming. More research continues to come. Our iSCAD registry currently has 19 sites enrolling across the country. So we're really excited because the more people that we have, the more we're able to have large cohorts and solid data to make recommendations with. So without further ado, I want to introduce our panelists. So Dr. Malissa Wood is coming to us from Boston. She's director of the Women's Heart Center at Massachusetts General Hospital and iSCAD steering committee member. Charlie Izard is coming to us. He's in North Carolina. Charlie is a SCAD survivor. He has been married for 36 years and has 4 daughters. Previously worked in banking and has been retired for the past almost 2 years now. So thanks for joining us, Charlie. Thank you. And Jeff Hawksley is coming to us from Maine, where there's not snow yet, but maybe any day now. Jeff married and has 2 kids and has worked in athletics as a coach for most of his career, training clients and coaching kids. So we're really excited to have all 3 of you here, and we look forward to the conversation. So I want to start with our 2 patients and invite each of you. We'll start with Charlie and have you kind of share some of your story, especially for guys and all patients newly diagnosed with SCAD. I think there's just so much encouragement in knowing that you're not alone. So I'll pass it over to you.
Great. Well, thanks, Rebecca, and Dr. Woods, thanks for being here. And Jeff, nice to meet you. Glad you're here.
Nice to meet you.
I guess the best way is just describe how my first SCAD event took place. And mine was in 2013, and I was visiting my daughter who was in a school play up in Massachusetts, of all places. And I've been very active in athletics my entire life. I've been a collegiate athlete. I do a lot of skiing and those kinds of things. And so I was on a treadmill in the basement of the hotel that we were staying at and just doing my normal workout, and my arms started to ache. They didn't hurt necessarily, but they certainly ached. And so I cut my session short, which is very unlike me. And I went up to our room, and my wife was there on her computer, and I just said, I'm really tired and I want to lie down and take a nap. And so I just flopped down on the bed, and we had just come from a warmer climate, so my hands were tan, and she noticed that my hands were as white as a sheet of paper. And so she just started Googling white hands and what that meant. And she got onto, a cardiac issue. And so she got us to the local care center And then they sort of figured out what was going on with me and then put me in an ambulance and drove down to Lowell, Massachusetts, where I had 2 stents inserted into my LAD. And if it weren't for my wife, who is now my guardian angel, it probably never would have made it out of that hotel room. So that was sort of the circumstances behind mine. And then 4 years later, the stents failed. And so I ended up having open heart surgery. Again, the tell for me was my arms started to ache. They didn't hurt, but they certainly ached. And this one wasn't as acute, so I had a little time to get prepared to do that. But those are the 2 sort of events that changed my life forever. It's definitely forced an early retirement on me, which I'm okay with, but it forced a change in so many things, like the things I used to love to do, I can't do. And just managing the psychology behind that, I think, has been personally the biggest struggle for me, which we're getting through, but it was certainly an issue early on. So in a nutshell, that's what happened to me, and I'll pass it back to you, Rebecca or Jeff.
Yeah, absolutely. Wow. I'm wondering if you would be able to talk a little more just some of those changes. You mentioned the early retirement. How have you kind of figured out what works, what gives? How do you find that balance?
A lot of trial and error, let's put it that way.
Right.
You know, as a SCAD survivor, you know, you're not supposed to lift anything heavy, as an example. And my wife is 5'3", 110 pounds soaking wet. And so whenever we travel anywhere, she's picking up all these big suitcases, and I'm 6'4", 200. So that's a little bit funny to work around. But I don't know. I think you just got to sort of realign how you think of what's important in your life. I used to think of things as the physical aspect was so important, and it's just not. There are other things you can do that give you the same kind of satisfaction as that. And so we've just realigned how we go about our day, the kinds of things that we do. I think I've been very lucky in the sense that my priorities while I was working was work, work, work. And now my priorities are much more family and community centric. What can we do to improve the lives of others versus what can we do to make our family's life what it needs to be? So it's a realignment. And, you know, they say there's things like this can be a blessing. And honestly, I think that's true for us, certainly.
Oh, absolutely. And thank goodness for your wife and for you, you know, being able to navigate through those things together. Jeff, I want to go ahead and pass the mic over to you for tell a little bit about your experience and with the SCAD event and afterwards.
Well, mine started as a mild heartburny kind of thing. I typically don't get heartburn. It was through almost a full entire day. And then later it was an upper back achy kind of feeling, and went through the night, slept, but woke up feeling exactly the same way. So we decided to go to a clinic about 40 miles from here, and we drove ourselves, and they did some tests, original tests. They didn't think, gee, it doesn't seem likely that you would be a heart patient. And they took the blood tests, and I forget the hormone or whatever it is that shows up in the blood if you're having a heart issue. Tell me what it is, would you? Because I've forgotten it. What is it?
Troponin.
Yeah. Okay. Thank you. And so they immediately put me in an ambulance and drove me another 80 miles to a larger hospital. And they quickly did a cath and determined that I had, well, actually, they did not determine this right away. The cardiologists need to put their heads together for a while. But in the end, I ended up with a dissection in the very lower portion of my heart, very small artery. No stents or anything needed to be added. And I left there, I was there maybe 3 days. didn't feel great. And then ended up at the original hospital I went to for a little cardiac rehabilitation. They put me on the typical blood pressure, cholesterol drugs, although I didn't have high cholesterol nor any blockages of any kind. And so from there, I saw a cardiologist once a year for 2 years and maybe 3, and decided after that it was time to be off the beta blockers, I guess they were, and to get back to life as normal. He told me my heart almost definitely had healed and do what I felt like. And that's what I've done since. Not long after that, at the time I had this issue, I was doing some trail running competitions. I went back to those eventually, and went back to life more or less normally, just making believe it never happened. And you mentioned lifting, and I lift, and maybe it's not wise, but I lift now and I lift heavy, and that's what I do to take care of me, is to be physically strong for what I do, relatively physically strong for what I do. And that helps me with the energy, motivation, et cetera, to do my thing. So I just feel extremely fortunate and never think about it. Thanks, Rebecca, for reminding me. With your so I feel extremely fortunate, and perhaps I have my head in the sand and should be thinking differently, but mostly I'm just going full steam ahead, and fingers crossed when I think about it.
Yeah.
But there's much to add to that.
Wow, absolutely. And it sounds like both of you guys, were extremely active before. And then, so I imagine that has been a big part of recovery too, is figuring out what works, what works.
Right.
I want to go ahead and jump to Dr. Wood because I don't want to ask all my questions before she's about to explain things, to discuss, we've gotten to hear kind of the 2 patients, 2, almost in some ways similar, active, healthy men who, the heart people who you don't expect. And I think that's kind of a recurring theme in SCAD, male or female, is that patient you don't expect. So I'm hoping you can shift to a clinical part of this topic, to give us an overview about what we do know in SCAD and men, and SCAD in general.
Thank you. And thank you both, Charlie and Jeff, for sharing your stories. Both of your stories, while they're distinct, are so familiar to me because, these SCAD heart attacks can happen in different ways, and very, very, sort of dramatic, obvious, something's going on, to something a little bit more subtle and kind of insidious that ultimately ends up bringing the patient to seek medical care. And I'm just grateful that both of you received excellent care and got the answers in a timely fashion. With regard to the, management and sort of the approach when you first present, I will say that it's quite common that SCAD patients are not your typical cardiac patients. And I actually, with one of my colleagues, wrote an editorial called Typical Symptoms in the Atypical Patient. And I think that's, sums it up nicely as to why I've really made SCAD and education about SCAD one of the passions of my career, because I feel like we have to educate first responders and clinicians in the emergency rooms to recognize that even though the patient may not have a traditional list, a litany of risk factors, if they're having symptoms, please check that troponin test. That troponin test will become positive within 2 hours if you're having decreased blood flow to the heart muscle. And now, thanks to these very, very sensitive types of troponin tests, we can really detect it at kind of the nanomolecular level. So just a little bit of decreased blood flow and that test will be positive. So if they send it, it's helpful. If they don't send it, we don't know. And Rebecca, I think I'll go ahead and show my slides if you would like, because I do sort of have a little bit of info in general on SCAD, and in particular to talk a little bit about what we know about SCAD in men And I just, again, I can't say enough about how much I appreciate both of you being here today, not only for people who may join us today, but even more importantly, for those who will be able to go on to the SCAD Alliance YouTube channel. I can tell you that I routinely refer my patients to the YouTube channel because these webinars are incredibly helpful with topics, mindfulness and stress management, exercise, the genetics of SCAD, vascular disease in SCAD, so many topics. And I think this will be just another jewel in the crown of the important, topics that are on the iSCAD or the SCAD Alliance website. So I'm going to talk, and I'll try to make this as clinically and sort of patient-centric as possible, just a little bit. And can you see my slides?
Yes.
Okay. About SCAD in men. And just to start out, assuming I can forward my slides, a little bit about SCAD in general. So, I think that we have now been looking at SCAD, sort of the Mayo Clinic and the Vancouver group really started with some really robust and informative studies. And now as we're going on to more groups around the world, and certainly now with iSCAD, we're beginning to understand a lot more about the setting in which SCAD happens and some of the potential triggers. And, the way that I think about SCAD is I think about the events that happen at one point in a person's life that may be associated with SCAD, and then people in whom those events occur that may have a higher baseline risk of developing SCAD. And those are people with an underlying vascular vulnerability. And I'll talk a little bit about that. And, usually when I meet SCAD patients, we try to kind of understand and get a snapshot of that person's health so we can kind of understand, are there overlapping circles? Is there a circle of an event that happened at a particular time, or an underlying condition, or, multiple things that overlap that kind of led to SCAD happening on that one day? And the reason I try to do that sort of house, if you remember that TV show, detective work, is that by figuring out kind of what was different about that one point in time, in some cases, when we can identify those unique things, it really helps us sort of figure out what to have the patient sort of not do in that way in the future, to give them some feeling of control over preventing recurrence. I think we certainly know that we don't know a lot about recurrence, but if we can identify triggers, then at least we can somewhat manage those triggers in the future. So when we think about triggers, we think about things that may cause an increased adrenaline surge in the body. So things that are either physically a real tax on the body, such as a sudden, lifting of something very, very heavy, or exerting oneself at a level that's much more than you're used to. So, while athletes certainly can have SCAD, it typically occurs in a setting of doing something that's above and beyond what they're normally used to. And when adrenaline courses through our veins, it causes increased cardiac output, or the amount of blood the heart pumps, as well as increased blood pressure, increased heart rate. And those things can all put a little bit of stress on the blood vessels of the body. So those emotional stresses can also cause adrenaline surges. So bad news, something that's really stressful in a bad way, or something that's really emotionally uplifting in a very, very good or elating way, has also been associated with SCAD. Intake of large quantities of cocaine has been reported, unfortunately, in patients, as well as large quantities of caffeine in certain patients, and caffeine-containing beverages. So those have been associated with SCAD onset because they also increase that stress on the body's vascular system. We know in women, hormonal exposure or sudden hormonal changes, such as with pregnancy or the postpartum state, can also be associated. And we think of those almost as causing a transient vascular change or vulnerability. Other conditions that can cause the blood vessels to be vulnerable to SCAD include underlying fibromuscular dysplasia, or that condition that causes excessive muscle in the wall of the vessel, and also can be associated with aneurysms, dissections, and abnormalities in blood vessels outside of the heart. Additionally, genetic conditions such as Ehlers-Danlos, Marfan syndrome, Louis-Dietz, and other types of what we call vasculopathies that are different from fibromuscular dysplasia And then less likely things that are inflammatory conditions can also rarely be associated with SCAD. So these are just some of the things that we have seen that can lead to SCAD. And then when we think about some of the differences between heart attacks in women and men, and overwhelmingly, there's more that's similar than there are things that are different. But we know that men are more likely in general, and this isn't specific to SCAD, to present with what we call ST segment or STEMI elevation heart attacks. And that's where there's an abrupt closure of the blood vessel that causes sudden ischemia or reduced blood flow to that muscle. And that can cause a lot of problems with sudden chest pain, rapid beats of the heart, or even cardiac arrest. Women, in fact, sometimes are more likely to have non-STEMIs, which is where the artery doesn't close completely, but there's decreased or intermittent reduction in blood flow. And certainly, as you can see here, the things that cause heart attacks, such as plaque rupture, which is probably much more common in men than women, embolization or blood clots into the artery, SCAD, certainly more common in women, we think, than men, but certainly can occur in both. And then on those outer circles, you can kind of see some of the conditions that can be associated with heart attacks in women than men. And I'm happy to share these slides with Rebecca and Catherine to distribute if you'd like to see them after. This is a table from Dr. Tweet and Dr. Hayes's sort of 2012 paper that really put SCAD on the map and really raised everybody's awareness about SCAD from Mayo Clinic. And I think what was important, a couple of things here. First off, not a lot of men in this study, only 16 versus 71 females. But what they found was that, you know, in these individuals, men were more likely than women to have that STEMI or ST segment elevation where there's that complete obstruction than were women. And these are SCAD patients, of course. And that was one of the sort of key findings. And then additionally, they also found that men were more likely to present with physical activity as the trigger of their SCAD heart attack. And so I think that that's kind of been, up until recently, really replicated across the studies, albeit all of the studies that look at SCAD overwhelmingly have larger numbers of women than they do men. And in this series, they looked at other things, you know, vascular conditions as well. But again, I think it's really hard to interpret the differences between men and women when you have so few men in their study. At MGH, we also have a registry of patients that have been seen in our program, and we've published that data. And we found, similarly to Mayo, that men were more likely to have that STEMI. And if you look at the type of SCAD, we think there are different, you know, forms of SCAD we know that have been well described. There's something called type 1, and that's where you have the tears. You can see here where it says the intimal tear. And those are where you have a more sort of obvious form where you can see kind of the dye lingering in the artery after it passes on a catheterization. And sometimes there's like a tear or a flap. Men are more likely to have that form. Women are more likely to have the type 2 of SCAD, which is where there's the thickening of the wall from the blood accumulation in the wall. And one way that I help my patients understand and think about what happened in their artery with SCAD is that it's almost as if there's a sprain in a muscle. When you think about what happens when you sprain a muscle, you either tear the muscle or you injure the muscle and the muscle swells. Well, this happens to be a sprain that occurs in a very important muscle, and that's the muscle inside the artery of the heart. Now, like sprains that occur in muscles in our body, these sprains in the heart also heal, but it just takes time. And when that sprain or that SCAD causes abrupt reduction in flow, that's when patients really have a more aggressive or more obvious symptoms, and oftentimes will be more likely to be the group that will need to have some kind of opening of the artery when the artery is completely closed. In our group, we also found that men were more likely to experience symptoms with physical activity. But interestingly, when we asked about underlying emotional distress, we did find that men were much less likely not only to report that they did not have emotional stress surrounding the time of their event, but they were also much less likely to report that they had underlying stress, anxiety, and depression. In women with SCAD, nearly 30% in most of the studies that have been done, those women report pre-existing stress, depression, and anxiety that, of course, in men and women occurs after SCAD. And we don't know, is that because the men maybe were less likely to report that it existed? Or maybe, in fact, there is a significant, which we think may be the case, sex differences in the actual prevalence or existence of depression in men in general compared to women. We certainly know that women are much more likely to report experiencing SCAD in the setting of that sudden emotional distress in the setting as well as chronic depression or anxiety. And again, this is some work from our group, which demonstrated, if we looked at the factors that are associated with SCAD, that women were more likely to have a history of migraines, more likely to have depression and anxiety, men more likely to have onset during exercise, women more likely to have onset during emotional distress, and women were more likely to have SCAD at the time of presentation in more than one vessel. Men, again, more likely to have that form of SCAD called type 1, where there's a tear in the wall of the vessel. Now, this is some recent data from Great Britain, which I'm including not to confuse you, but just to show you that I think we need more data. We need our men, we need our doctors to recognize SCAD in men, and we need our male patients to really engage in ongoing research so we can understand SCAD more. I will tell you that I've looked at a data set of patients under 50 who experienced heart attacks in the Boston area, and this is unpublished data where we did a retrospective where we went back and looked at the angiograms, and we found that many males had SCAD, but it was overlooked because I think we don't typically look for those smooth narrowings that are present in type 2 SCAD in men. We think of that being much more common in women. So I think there's a little bit of a bias on the part of the medical professionals. I think that we all need to carefully look at our patients when they present and carefully look at their angiograms. This data from Great Britain showed that, in fact, men and women had equal likelihood of presenting with those two different forms of heart attack, STEMI and non-STEMI. And they found that the type 2 SCAD, again, the smoother appearing SCAD, was equally common in women and men. So a little bit different than the Mayo and the work that we did at Mass General as well. So I think we're still kind of trying to unpack why different groups are seeing different things, but I think it boils down to the fact that in most studies, fewer than 13% of the patients are men, and that's really going to limit our ability to understand. Now, I co-edited a book looking at sex differences in heart disease this past year, and this is a chapter. This is a figure from chapter that Dr. Tweed from Mayo actually contributed to our book, and this is sort of just going through the whole experience after SCAD of the patient and the different things that we have to think about, and certainly that would include the medications. You know, we could talk probably for hours about that acute management, but once someone has been found to have SCAD, certainly patients will be on aspirin and probably a beta blocker long term. And I'll just mention that in men, that's something where you want to have that individual discussion with your doctor if you're experiencing side effects on medications, and men may have different side effects than women. You will want to discuss it, but we certainly do believe that beta blockers reduce the recurrence risk. Now, everybody, men and women, we'd like to have undergo that vascular screening to look for FMD and to look for other vascular conditions. We know that in many people, there is a family history of underlying conditions that may predispose one to SCAD, and those would be things like a parent or a sibling having a heart attack or a dissection in either the aorta, the brain, or the abdomen, or certainly SCAD. And so it's important to know your family history for all of us. It's also important to be aware that men and women both experience sort of a phantom or ongoing discomfort, even when the arteries heal. And that improves over time, but it's something that we do, warn our patients about. And it's certainly important for you to talk to your patient or to your doctor about what types of symptoms would lead you to go back to the emergency room or to call your doctor and let them know that you're having symptoms. Things like reproductive counseling are very important in our female patients because we have to talk about whether or not they're going to be able to have a baby in the future, and some of the considerations. Those are not really pertinent in men. Now, men, excuse me, may have migraines, and there are certain medications we're going to want to avoid in men with migraines. Now, I know Charlie mentioned this, and I think it's so important to really recognize the psychological impact of having SCAD and having a heart attack in a previously healthy male. I mean, the men in our families take so much responsibility and carry a lot on their shoulders, as do the women in our families. But I think oftentimes it's very hard to sort of cross that threshold of, I was a strong, healthy man one day, and the next day I was a heart attack patient, and not only a heart attack patient, but a SCAD patient. And I think that in some ways, when individuals have a heart attack from a plaque, at least we know that there are very clear guidelines that we can follow. And we know that if we put a stent in and we treat with statins and follow symptoms, that patients with plaques from heart attacks, we kind of know what to expect, and probably unlikely that they're going to have another problem in the first few years after. And versus SCAD, where I think we still are learning what to expect and what can help us prevent recurrence. So I think that uncertainty certainly adds to the psychological stress. And that's why it's so important that if you're suffering from either depression or heightened anxiety, that you talk to your doctor, consider seeking a therapist, and really work with your loved ones and that circle that you have around you, so that they understand not only what you're going through, but also what they're going through as the people who love you and care about you. And I know Charlie, Kathy, your wife, Kathy, has written about that, and I'd love to hear a little bit more about that in a few moments. Now, with regard to physical activity, and I think Rebecca did tip us off on this, and Jeff mentioned this as well, we do kind of give some recommendations to our patients. And the first recommendation is to get into cardiac rehab after you've recovered from your SCAD. Certainly we let people heal. We let them sort of get to the point that they can walk comfortably without symptoms, and then get them into cardiac rehab. It's so important, because cardiac rehab not only helps with the physical activity, but also helps with their recovery psychologically following SCAD. It gives you those guardrails and parameters that you should follow. And for most patients, we recommend that when you resume your activities that you enjoy, that you try to avoid going into that anaerobic zone. And that anaerobic zone is when you're exercising to the point that you cannot carry on a conversation. Now, if you're doing high intensity interval training where you do that for short, very prescribed periods of time, that's probably okay. But to sort of continue doing something that's anaerobic for long periods of time probably is less beneficial to your heart and may even be concerning. Now, we do give weight limits for lifting, and those are really based on data that we are extrapolating from what we do with our patients who've had aortic dissections. I will say that they aren't based on really any evidence, but they're based on prudent thought amongst a group of doctors who manage SCAD patients. And we really do try to kind of set that number at about 30 to 40 pounds. I know that's not a lot of weight for people who are used to lifting, super heavy weights. But we do recommend that if you lift, that you don't hold your breath when you're lifting. And what we really want to avoid is people doing sudden, jerky movements of lifting very heavy things and holding your breath, because we know that that's hard on your blood vessels. Now, for people that really love their athletic, experience and want to continue sort of aerobic activities, at least in our organization, at our hospital, we recommend something called cardiopulmonary exercise testing, which is what you hear about sort of the lead athletes doing, where you exercise and they measure your VO2 max. And that's your body's number of maximal oxygen consumption. And then additionally, they also are able to tell you at what heart rate you go from aerobically exercising to anaerobically exercising. And then we have people exercise usually at about 10 points below that anaerobic threshold heart rate. So that's actually really detailed data that's very helpful for those who want that. Now, finally, I'm going to talk a little bit about things that we have been doing to help manage the stress after SCAD, which I think is, again, universal and maybe heightened, especially in those with pre-existing anxiety and depression. But, you know, we've offered group visits for mindfulness and group visits for education about SCAD that are virtual so that we can get groups of patients together to learn more about the nuts and bolts of SCAD and really to answer questions. We've also offered group visits to really talk about ways of incorporating more stress management into your life. We've also developed something called peer mentoring, which is where we individually match patients who are new on their SCAD journey with someone who's kind of a veteran and has been through it and is feeling better. And that sort of matching has really helped patients. We also work with an embedded or have access to a cardiac psychologist who has helped us with our patients really struggling in those early months after SCAD. And I think it's so important to really understand that it takes a village to care for SCAD patients in those first few months as you get your wings and really kind of resume life. And I like to think about SCAD as an experience that occurs. And after SCAD, we want our patients to feel more empowered and even stronger and more resilient than they were before, so that you take away from SCAD something that hopefully is very positive in your life. And I just want to again shout out the iSCAD registry, you know, well over 700 patients now. These are the active sites. If you're a SCAD patient and you're a male SCAD patient, you haven't been able to really see a SCAD specialist. There are many SCAD specialists around the country, but certainly these sites are enrolling in the registry. These are some resources that are available. As I mentioned earlier, the YouTube SCAD videos from not only our MGH patient series, but also most importantly, the SCAD Alliance YouTube channel that has dedicated programming. These are some books and websites. The SCAD app was created by a group, and I was part of that by the University of Colorado. It's free and it's available to SCAD patients. It has a lot of tools for psychological recovery after SCAD. So finally, just to conclude my remarks, data do suggest that there are differences between men and women with SCAD. It appears that SCAD does affect women much more commonly than men, but we think that there may be some bias on the part of physicians not recognizing SCAD and maybe perhaps calling you know, when people do have heart disease, calling it atherosclerotic or caused by plaque, when in fact it's SCAD. And I think we just need to do a better job of ongoing education, not only of those caring in the first moments, but those doing the procedures. We need to get more men involved in research, especially in our registries. And I think we want to continue to work on ways to not only support our patients, but also to support their families through some of the things that I suggested. And with that, I will stop my content. I'm happy to take questions and sort of hear more from our panelists.
This is phenomenal. Thank you so much, Dr. Wood. I think, you know, just to have that understanding of where are we, you know, from a medical standpoint. A couple questions. One I want to put out to all of you is that physical activity piece. I know you mentioned that in detail, but I want to talk more just because, Charlie, both you and Jeff, we're so physically active. And so let me make sure, are you able to unmute yourselves or?
Yep.
Okay. You know, so I'm wondering if each of you could talk just about your own experience, kind of what you were doing, you know, physically, kind of where you were before, and how has that changed and how you got to where you're at. Jeff, I think you mentioned doing cardiac rehab as well.
I don't want to, I've done everything wrong in according.
No, well, I think that's
Dr.
also going to
Wood.
lead into my next question, which is going to be about finding, you know, that weighing of the psychological benefits too, which I think is a really important aspect as well.
There is no wrong, there's only different. There's no wrong.
That's right. That's right. I'm for a while I was depressed, kind of just sort of lethargic and not real motivated to do a whole lot right after. But then, you know, this has been, you know, I apologize. I do not know the date of my event, but it has been a good while ago. Okay. Many years. And I eventually ended up doing trail racing, which is highly, you know, you're working at way higher level for a good while than probably would be recommended. I didn't start doing that instantly, by the way. That was a long process. Out of just a joy to be in the woods and trail run, and then had some friends that did competitions, and so I went and did them. And I did stop them. I stopped them for not because I have pain, but ankles, knees, and hips. I'm old enough to know that, there comes a time when it might not be smart. Also because I'm really competitive, and I sensed intuitively that hammering my heart all that hard was probably not real wise. But I don't think that I even thought about SCAD. I just thought about my age and efforts, and it'd be better to not do that. Okay. So I stopped doing that. I do play soccer with my soccer team, and I'm active that way. But the thing that really jumps out is I lift quite heavy. And I do sort of instinctively now a breath holding or balsamic maneuver. And the weights are considerably more than my weight, some of them. I do low reps. I do not do high reps. And the workout lasts anywhere from 15 to 20 minutes and only about 5 sets. Okay. So 5 sets, 3 to 5 sets of 5 reps. So for instance, a bench press would be a certain amount for 5 repetitions times 3 or 5, depending on what I'm doing that day. And I'm in and out of my basement gym very quickly. And the rest phases are quite long. They're anywhere from 2 to 5 minutes between sets. But the actual RPE is high. Okay, the last rep is extremely difficult to do of each set. All right, so I do that with all the traditional heavy lifts: bench, overhead press, deadlifts, and squats. Okay, and cleans. So there are phases when I work out almost every day, and then I'm very busy in soccer right now, so it's more like an every other day to every 2 or 3 days. But I don't know that that's as big a factor as the loads are really high. So I'm sure they're way above any common sense recommendation. I wonder if a lot of that was part of what I did as life anyway, is a reason why it perhaps hasn't hurt me yet. But honestly, you may not know, and I don't know. And so in the sense of your recommendations, I kind of am not really a proper model, probably.
Well, actually, one thing that you mentioned is that kind of listening to your body. And while I know you didn't attribute that necessarily to SCAD, I'm curious if that is something that you kind of developed, in terms of, you mentioned it with the trail running, just like being able to listen to your body and saying, hey, like this is the point when I, change what I do. And I'm curious if that, and you may not know either, but if that was kind of just as a result of the fact that you've been so involved in athletics your entire life, that you have been really listening to your body, or, I know for some patients that comes after having a medical event, that's kind of a trigger to start just paying attention more.
Well, I tell my clients that when they're working out, that their progression, I typically don't prescribe much in terms of a progression. They more or less do it themselves when their fitness level just gets to the point where they feel, okay, I can add 5 pounds to the bar. I can go a little further on a run or a ride, and it's not because it's prescribed, it's because they feel fit and healthy and strong, and they just do that. And that's their way of just progressing their work and getting better and better. But I will jump in to say that our fitness industry is not doing anybody any good in a lot of ways because of the high intensity workloads that people are prescribed by some trainers. They really are. It's excessive, and it's not healthy. It's especially not healthy for new people. And it's one of my pet peeves that I see on all the social media outlets and Facebook and Instagram and all these different places where online trainers are training with people. And I'm surprised they're not hurting more people than they are, just based on their intensities and volumes.
I'm just gonna say, I'm not calling out any discipline of exercise, but I will say that there are people that have come to see us that have been doing sort of very, very high intensity, probably beyond what's good for you exercise. And I think, again, it's important to know your history. It's important to know your own health. And we want more than anything for people to remain very physically active and routine exercise to prevent heart disease down the road. But, being prudent and being thoughtful and working with your doctor to understand, everything is kind of, we call it shared decision making. I tell my patients, like, if you like to deadlift 350 pounds, you're probably not going to like what I have to say, but I'm going to tell you, and then ultimately the responsibility will be yours, but we will understand as we move forward, because it's, you have to enjoy your life, and there's quality of life too. So
Can I ask a quick question? So would that type of loading be cumulative or acute? In other words, would the damage to me doing what I do be a cumulative damage or acute in the moment damage? What do you think?
all I'm going to say is based on what I know about the physiology of weightlifting, and I actually did work with the U.S. Olympic weightlifters in the 2008 Olympics. It's closing your glottis, straining, lifting the load, holding it, and then putting it down. So it's pretty immediate. If we think about the whole type of what happens with different isotonic versus isometric exercise. So.
Yeah. Acute, so more or less acute, right? Is that right?
Yes.
Okay.
Excellent. Charlie, I wanted to hear from you too, because I know my experience was probably very similar to yours, in that after that event really had a big impact on how I viewed life and priorities. And how have you navigated that in terms of finding what physical activity works well, how you stay, excited about that?
Well, I guess that's why Jeff and I are on, because he's clearly not a rule follower and I am. So we'll bring you both perspectives.
Absolutely.
So I used to do a lot of quick step sports. So tennis, ice hockey, skiing, something that took your heart rate from 0 to whatever pretty quickly. And then I was advised that it needs to be slow up, get to a plateau, and slow down. So I've changed from doing those kinds of sports to hiking, walking. I'll get on a treadmill, I'll get on an elliptical, that kind of thing, but slow up, slow down. And we're, Jeff's probably lifting 300 pounds in a deadlift. I'm at 20 pounds on each arm in a curl kind of thing. And that's just very different. And so instead of doing the things like skiing and tennis that I used to do, I've taken up fly fishing and some other things that are just much less stressful. But I still do a lot of hiking. I hike a lot, and that gives you, some endorphins, not like the ones you used to get, but it does provide some.
And do you and your wife travel a good bit? So I imagine that's quite a bit of walking as well.
We do, we travel. She's carrying the bags, but we're traveling. Dr. Wood, I had a question. I had a follow-up for you. I noticed in one of your slides that it said that a lot of the occurrences take place in the LAD. Is there something unique to the LAD as part one? And then part two, for those of us that have had CABG procedures and the mammary artery was wrapped around, would that suggest that we're in a better position than maybe we would have been with a stented LAD?
Sure. So good questions, Charlie. And I guess without asking you to divulge too much information, I'm going to say, if you have a Lima and you told us your stents didn't work, I'm going to assume that they were placed in the LAD.
Yes.
Okay. That was my thought, but I just wanted to be sure. So the LAD clearly in men and women looks like the most common artery. And, it's kind of a straight shot down the LAD. It typically carries like a lot of the flow to the largest part of muscle, which is the front part of the heart. And so there's really strong flow down that vessel. And, you know, there's some different theories on why people develop SCAD in general, but one of the things that we have observed is that, at least this is in a perhaps a small group of SCAD patients, but in some, you know, that thing called broken heart syndrome that happens in the setting of emotional or excessive physical stress or other triggers, the heart beats like extremely strongly at the top, and then the middle and the bottom of the heart kind of just stops beating, and it actually just kind of just sits there. And we think that that pattern is triggered based on the way that adrenaline affects the heart muscle. And you have that innocent little artery sitting on top of that heart muscle that all of a sudden is like beating like this with an angle like that. And we think that in healthy arteries in some patients, that the heart muscle suddenly having that vigorous motion causes the artery to tear. Because when we look at people that have SCAD involving and also have that broken heart pattern, the point at which the artery seems to have the beginning of the SCAD kind of correlates to where there's that junction between the hyper or strong part of the muscle and the sort of part that isn't working very well. So the LAD seems to be seated or positioned in a way that it may be way more susceptible in patients that have that form, for sure, because it's kind of straight going down the front. Also the flow characteristics. And, you know, it's also that perhaps it has less turns. The arteries that go around the side and the bottom of the heart have more turns. And it may be kind of like when you ski, or you have skied in the past, and you're going down the Black Diamond and you suddenly turn, you're going to slow down your velocity. So it may be that those curves somehow slow down the velocity of flow through those vessels in the setting of high stress. And maybe slowing it down kind of prevents in some way, at least the initiation. Now, these are just theories. I clearly want to say that these are not proven facts, but we do know that there are different flow characteristics in the different vessels, as well as just the geographic location. So that may be one thing. With regard to your question about the bypass graft, I think certainly knowing that there is a backup blood supply is really helpful. You know, I will say that we do recognize that in patients, not like you, because you had the bypass because the stents were not working. So the vessel was kind of in jeopardy. It sounds like probably not because of SCAD, but maybe because the stents developed some scarring inside of them, which can happen even in SCAD patients, that they're just, the stents are foreign material in your body. And so in your case, that lima, or that vessel that's used to bypass the LAD, it's very likely to have gotten really plump and delivering a lot of blood flow. What happens when we do bypasses in patients with acute SCAD is that the SCAD, because it heals, suddenly that bypass graft has competition down the native vessel. And a lot of times those bypass grafts don't stay open in patients in whom bypasses are done acutely for SCAD. Now, they certainly get people through that rocky time where the heart needs, you know, blood flow, but we find that they actually, the majority don't stay open long-term in people in whom it's done with acute SCAD, and that's very different from you.
Interesting. Thank you.
That is. One question that came up on Facebook, and I want to, it kind of transitions to what was my next question, is let me actually just read it from here. So somebody mentioned that they had their SCAD during a physical event while they were practicing, while they were competing, and that mental component of getting past that, you know, doing those same activities. How do you guys, you know, kind of get through, you know, or get back to those activities? Charlie, did you do cardiac rehab?
I did, yes.
Was that a factor for you, or were there kind of other things for, you know, I know you mentioned kind of doing some different activities, but some, you know, are there things you guys recommend or have found that have been helpful for you?
Yeah, I personally found that you just have to find things that you feel confident that you can do and not create an issue. And mine was a little bit different than Jeff's, but so I felt like start walking, build confidence that that's going to happen, start hiking, start being more aggressive. It's very incremental in my mind. The
Mhm.
idea of lifting 300 pounds like Jeff would, if stress creates an event, that would give me an event thinking I had to do that. So it's
Not even the physical part, the
yeah, I think it's just personal,
right.
how you think you can manage it enough to get to where you'd like to be. And, for me, I thought about it a lot the first time it happened.
Absolutely.
And then slowly I've stopped thinking about it because the routine I'm in, and I think routine's an important word, you get confidence in that routine. And as long as you stay on that routine, you sort of feel like you're not at risk, because if it didn't happen yesterday, it's not going to happen today, and it's not going to happen tomorrow.
Yeah, there's some safety in that for sure.
Yeah.
I would add that, as I mentioned, it's been a long time since my SCAD, okay? And I did exactly what Charlie's describing, okay, for months and maybe 2 years, maybe 3 years of just not necessarily thinking about SCAD, but just coming back slowly with very short runs, and I wasn't lifting a lot, and I was just going slow and slow and slow. And it just evolved, and in like I've mentioned, intuitively built into the things I do today. But I was still for a good while, okay, concerned and attentive. So I think in a lot of ways, right after the SCAD, the whole process for perhaps many, many, many months was pretty much identical to what Charlie described. It's evolved beyond that at this point.
Yeah, absolutely. And I appreciate you guys kind of talking through that, because I think there's so much about all medical vets, but it's, we're talking specifically SCAD, that is individual. And that is that kind of figuring out your comfort level with your body and your, cardiologist, to find that right balance. I want to ask about support, kind of jumping from there, and that, how have, so as an organization, SCAD Alliance, we, help monitor some social media groups. We really help support patients, but we don't find that the guys are super active in these, which is fine. I'm curious where you two have found support, and also Dr. Wood, where have, patients, especially your male patients, found support? Who wants to start?
Was
Dr.
that
Wood.
direct?
I'll have Dr. Wood start, and then I'll pass to each of you.
I actually, I hope that our patients find support from us, the care teams. I know that I want their families to come with them. I mean, thank goodness now that things have lightened up a little bit with the pandemic, we're able to allow loved ones to come into the visits. And I always feel like every patient should bring someone with them to the visit, but I want to educate not only the patient, but their loved one, their family member or dear friend, because I feel like the people who are with them every day are the ones that will give them that support, but I need to help them feel comfortable, and education goes such a long way. So first, care team, second, family and friends, but obviously cardiac rehab, huge part of it. And feeling, I think one of the things for us that's really helped us is our patients know if they have a message, they can send it via Gateway, or they can call, and we will get back to them and answer it. And I call it the buffer zone, and I'm like, we provide you with a buffer zone so that as you go through recovery, or if something comes up down the road, there are people there to answer your questions. And I think that's really, really important.
Yeah, I'd like to echo that. I think Dr. Woods hit it on the head, which is your care team is number one, because there's so many questions around SCAD, and you can't go in and get sutured up and walk away and you're fine. It's all about a management process, and you need to be able to ask questions on a disease that is hard to get your arms around, really. And once you get that in place, and then your family together, is what I found is critical. But without a care team that really understands, willing to answer questions and deal with your concerns, it's hard.
Rebecca, I have a question here from Catherine. I know we're at the top of the hour, but this is a really important question. With the emotional stress trigger or due to stress over a longer period of time or lots of stress at one time. And we think it's a combination of the above. You know, many, at least of the women that I've met who talk about the stress in their lives, oftentimes teachers, it's an occupation where we see a lot of SCAD, particularly, you know, teachers of special needs children, where there's a lot of challenge. There's a lot of, maybe they don't get the support they need in their school system to really manage. And then maybe something acute, sort of the straw that broke the camel's back. Or someone who's kind of been cruising along just fine and something devastating happens. I would say that the former is probably more common than the latter, that maybe that chronic level of stress just really may change the biology of something, and then you have just that little push and things, you know, sort of break down.
Absolutely. Thank you. Thanks for getting that. One other thing that I do want to mention, Charlie, I'm wondering if we can promote this book too. Charlie's wife wrote a phenomenal book, just speaking of that caretaker support and that experience. You know, Dr. Wood mentioned the importance of family and friends helping out too. And I know, as for myself as a patient, I found it very encouraging. In terms of helping kind of find those next steps and figure out that process.